as I was saying, I'll just give you a brief introduction about myself. So, as a member of the medicines team, I tend to join inspections alongside inspectors and GP colleagues, and I tend to focus on the medicines management or optimization parts of the prescribing side of clinical practice. So I've got a background prior to joining CQC, and that's been, both in primary, secondary care, and latterly, before I joined CQC, I actually worked in the pharmaceutical industry as a regulatory advisor. Um, so that's a bit about myself. I don't know, Mary, if you wanted to add anything as well about yourself.
Yeah, just so you know, I'm one of the managers in the what we call our medicines optimization team. We don't like management, we like optimization. So, my role, although regional, so I have a regional role, which is London and East, which is obviously slightly different to you. But I have a role nationally for primary medical services. So any of the work we do developing our models or our inspection programs for medicines around primary medical services is where I get involved, and also independent health. So I've been involved in some of this work. I've been in CQC a very long time, and I've seen a number of changes. This is why I made the point that things do change. So pleased to be with you today, and thank you for the opportunity.
Oh, brilliant. So just a couple of points about housekeeping before we start. So Mary has kindly agreed to monitor the chat function because I can't see it whilst I'm sharing. So we can go through questions as you like during the presentation, or alternatively, I'll open it up to questions at the end as well. So you'll have an opportunity at both points to ask any questions, if that's okay. So today we've been asked to talk to you specifically about clinical searches that you may have already come across as part of the inspection process, or are due to come across maybe in the near future. So how they're used, the breadth of them, as well as being able to answer a few of the questions you may have around them, if that's okay. So let's have a look. So I guess the first thing to say really is the use of these clinical searches on CQC inspections has been the most obvious shift in terms of the clinical aspect in our inspection methodology in the past couple of years. And it sort of started out, I guess, just during the pandemic when it was getting underway, and we found that the approach was successfully used during the pandemic to reduce the risk from site visits for patients, practice staff, as well as CQC inspection teams. And it really involves accessing GP clinical records remotely, really, to systematically identify patient records for more detailed review of the notes. And for us to do this in a consistent way, at CQC, we've developed a set of clinical searches that's been produced in collaboration with Ardens, who's our partner, and that they are then uploaded and run on primarily System 1 and EMIS practices in advance of the inspection. So if a practice hasn't done this in advance, or if we haven't done this in advance, then either the GP specialist advisor or a member of our medicines team would upload and then run the searches on the day of inspection. Again, this is usually done remotely. Can I just check, do we have anyone who has vision as part of their clinical systems in this area?
No.
Okay, that's fine.
No.
That's okay. No worries. So yeah, primarily, I think we tend to deal with System 1 and EMIS whole anyway. So okay, so before I get to the sort of clinical side of it, I just wanted to do a quick explanation of the logistics of how this works in case anyone hasn't come across it yet. So we have obviously GP specialist advisors as well as pharmacists and clinicians who then provide the practice with their professional registration details as well as their smart card number. And then the practice then sets them up temporarily as a clinician on their system and provides them with any access codes that they would need to enter. The CQC team just so you're aware, will be using their own CQC equipment, which is securely encrypted, and access to that should then obviously be time limited just to involve the inspection process. A side note, and I've had personal experience of this as well, it would also help if we appreciate practices have alternate systems to do things like review hospital letters, blood results, etc. And if we could then be set up on these systems too, and an explanation of, I guess, given to our lead inspector before that happens to avoid any confusion on the day of inspection, then that's much appreciated too. So the purpose of the search is to identify obviously any potential clinical risk in relation to the safety and effectiveness of care delivery. They do have a high degree of tolerance built into them, and that's really for us to just identify any significant outliers within the searches. So the searches, which relate to medicines anyway, cover a wide range of areas, which you can probably see there. And some of them include monitoring for things like high-risk medicines, so things like DMARDs, lithium, DOACs. We also do searches around MHRA safety alerts, and situations where national guidance or reports suggest prescribing might be a concern. So obvious ones being things like the long-term use of hypnotics or anxiolytics, as well as the prescribing of, for example, SABA inhalers or lots of them to asthmatics without an appropriate review. Before we go on, have we got any questions, Mary?
Sorry, no, carry on.
Oh,
Somebody's just commented that it's a shame they don't have access to Pincer anymore.
Yeah,
yeah.
It is a shame.
Mm.
But we are constantly, just so you're aware, we are constantly working through methodology all the time, and we do review sort of suggestions, and a lot of it's down to our policy and methodology colleagues at CQC as to what gets included, with obviously clinical input from sort of national advisors as well as our CQC medicines optimization team. So just moving on, there was something I did want to bring attention to. We know obviously that clinical searches are a very blunt tool to simply identify sort of numbers and cohorts of patients for further examination. And this is why I wanted to stress to you, they're never used in just isolation by themselves. So the numbers are never used just on the face of it. So the clinician assigned to the inspection has to undertake a clinical notes review of a proportion of patients identified by the searches, and that's to consider the overall quality of care. So this, just to reiterate, the inspectors don't just look at numbers of patients identified from the searches and draw immediate conclusions about patient care. It is the clinician, so either GP advisor or pharmacist or someone similar, that samples patient records, and then they're responsible for completing a data collection sheet. It's a bit like how you have an audit data collection sheet to describe care for individuals. And then this is the data that is used to establish the overall practice's position on these aspects of care. Okay, so unless we've got anything else, I can move on to some of these searches. So if we start with monitoring, essentially the practice should be able to evidence that patients are monitored in line with national guidance, and that the prescriber is aware that it remains safe to prescribe that medicine on each occasion. So you can see examples of some of the searches here, and more information can also be found on our website under the CQC GP Mythbusters, which I'll point out a little later and come back to. And I just wanted to draw your attention briefly to one of the searches there that we do, DOACs. So we actually have a few searches looking at aspects of care relating to DOACs. And one of the biggest issues or concerns we've had, or we've identified, is that the monitoring of DOACs where creatinine clearance hasn't been calculated. And this is leading to patients obviously being prescribed perhaps the incorrect dose of their anticoagulant. So this is something we've noticed recently in terms of the searches and the reviews we've done from searches of practices. Okay, so one of the areas we look at medication reviews, and that covers a whole range of different aspects of care. I'll start by saying that CQC do not monitor or police the GP or PCN contract or DESs. So this isn't specifically looking at SMRs or structural medication reviews. This means that CQC can't mandate how reviews and repeat prescribing should be managed within each practice. We're just merely looking for evidence of assurance that appropriate medication reviews have been done, and that's in line with sort of national guidance, so for example, NICE guidance. So some of the things we're looking out for is that, all monitoring has been conducted or arranged or requested. Any medicines interactions have been considered and discussed and actioned. Any drug safety alerts have been actioned as well, including clear information if a patient remains on treatment included in the alert and the rationale for that, as well as things like concordance issues being noted and addressed. So if we find that a code has been added without these considerations being addressed, then we would consider that there being insufficient evidence of these medication reviews occurring. Before I move on, do we have any questions? You're on mute, Mary, but I assume there's
I
nothing.
can't unmute. There we go. Nothing in the chat, but do feel free to put hands up because we can be quite informal here. So, so do put your hands up if you want us to ask a question or divert into something else. We have time to do that.
Cool. So I'll move on to sort of MHRA safety alert searches. So this is another area where we would expect to see evidence of actions and implementation, and that's around MHRA drug safety updates. So there've obviously been numerous ones over the years, and realistically, our searches can't obviously address all of them. However, we have tried to include ones that are quite fairly obvious, where they have probably had the most patient impact in terms of sort of quantity and quality of care impact, and where actions taken would be clear to see from the patient records and thus producing suitable evidence. So during our inspection activity, we would ask practices to discuss and possibly demonstrate their processes for ensuring that there's adequate dissemination to all clinicians and how patients are identified for actions if necessary. I'd say one of the problems we've identified and have been able to alert practices to is when practices do not seem to have received an action historic data safety alerts. So our searches in that extent or that regard do cover quite old safety updates. And that's because we're anticipating that the advice from these will have already been incorporated into good practice. So for example, you'd probably remember the ones of like a maximum dose of 20 milligrams of simvastatin if co-prescribing with amlodipine occurs, or another one would be not routinely using omeprazole and clopidogrel combination. But we're actually still finding that some clinicians haven't been made aware of these and altered their practices accordingly. We've also seen situations where such combinations have been issued on his hospital discharge letters, and there've potentially been an error that has occurred or started at hospital, but is then perpetuated into primary care and beyond. So this is just something to be aware of. Okay, and then sort of looking at another section we look at is around the sort of risky aspects of prescribing. So this section looks at things like, long-term benzos or Z-drug prescribing, gabapentinoid prescribing without reviews taking place, and the prescribing, for example, there of lots of SABAs to asthmatics without a COPD type of diagnosis. So the clinician that we have on board will be looking at samples or records to understand that the prescribing clinician has taken these risks into account and acted accordingly. So perhaps by documenting a conversation about this with the patient, seeking additional advice, or even referring on to specialised care. Okay, I think I mentioned earlier that you could find out more information about the process of clinical searches and the rationale behind them. You can find out about those and lots of others, actually, if you haven't already done so, on our public-facing CQC website. So I put a link to it at the end of the presentation there, so you should be able to access Mythbuster 12, which covers accessing medicines records during inspections particularly. And, you know, like I mentioned, this explains things like the reasoning behind the use of clinical searches on inspections and the areas we look at. But I must stress actually that the examples given on the website are just that. They are just examples. It's important to note that the list isn't exhaustive, and it is altered and updated to keep it relevant as more information is received, for things like, for example, new safety updates as and when they're published. Do you have any questions before I move on to the last aspect I wanted to talk about? I think we've got a hand up.
Somebody's got a hand up, yeah.
Yeah.
Khaled?
Yeah, can I just ask a question? Sometimes it's appropriate. You talked about, you know, more than 12 SABs a year. I mean, a while back, we had one young person who asthmatic, also an opiate injector, under care of specialist hospital consultant in asthmatic teams. And the number of times we had a documented sort of re-referrals and sort of consultations with the consultant and the person themselves saying they really ought to be using the actual steroid inhalers as well, not just the short acting. And the person just kind of obstinately refused to do it, but it was well documented in the person's record. And I wouldn't consider that bad behavior by us, because the consultants very clearly said, and it was appropriate, that, you know, you still need to prescribe the blue short acting inhalers, because you can't deprive that person of it, because the consequence of them not using it is going to be a lot worse.
Yeah, I'd say the key thing there is the record keeping.
Yeah,
so as
absolutely.
long as the adequate records are being made on the consultation notes in the clinical system, then, and obviously it's auditable and it can be seen, then by our team, then that's perfectly fine. We understand completely there are situations either due to patients or, you know, the intricacies of perhaps what they're suffering from, or any number of issues where they may not want to take certain medicines, or where they might need some that fall outside and make them, I guess, a significant outlier when we're looking at searches. But again, the key thing is record keeping there. And there is also a process, just to reiterate as well, as part of our inspection process, if we don't find something perhaps in the notes, and, you know, we make a judgment about that initially from what you said, example, then there's always the process of the FACAT challenge, which can be used to demonstrate actually adequate notes were made, but perhaps they were, I don't know, on a separate system or somewhere else where we couldn't get access to them on the day. And we will then take that into account most definitely. So as long as it's clear or auditable, and competent, you know, adequate note taking is done on the clinical system, that's fine. Okay, do we have any other questions before I just wanted to finish off on one last piece? No? Okay, well, we'll take questions after this anyway, but just before I finish talking, I just wanted to have a quick conversation about how we're looking at competence. So one of the sort of emerging concerns that's being raised both within CQC and other regulatory bodies has centered around the oversight of staff, of clinical staff in general practice. So I'm guessing this is becoming more of a concern as we have new staff employed via the PCN contracts, and will very much depend on the arrangements you have between practices and PCNs for the employment of staff. But the key thing here, I wanted to go over is that staff are working within their scope of competence, and that the practice has some way of being assured of that competence and of being aware that the individual is receiving adequate support, training and supervision necessary for their role. So contrary to popular belief, CQC can't be prescriptive about the type of supervision used or what we would expect practices to have. We just simply look at the evidence that the practice is effectively assured of the competence of their staff and are providing obviously the adequate support for them to keep up to date and develop their skills. And that can be by whatever method they choose to do so as well, or use. So there are a few CQC and GP mythbusters that discuss this in more detail. So I would strongly encourage you to read those too on the website. So, I mean, that's actually, that's enough talking from me now. I'd actually like to open the floor up to questions now. So really, it's over to you guys.
Sorry, if I just say I've posted the link to the Ardens
Oh yeah.
website as well with the CQC, so that shows how you can download the searches for your own use from Ardens for free, regardless of whether you're an Ardens customer or not. They're available to everybody, so you can download them for your own audit purposes. And somebody has posted a question: is it the supervision? Are we talking about just prescribers or clinical pharmacists who are not prescribers but carrying out medication reviews? And there is, regardless of whether they're prescribers, there is an expectation that people work within their competency. So you'll be looking at slightly different competencies, but it's that people are working within their competencies. So that's you're still looking at the same thing. You're just looking at different competencies and different audits and any different ways of supporting that person to do their work. We also work, CQC does do a session on all the CPPE, PCPEP pathways for all the pharmacy professionals that are working into GP practices. So we do emphasise that point to them directly as well, to yourselves. And we've got a hand up as well. I've lost the hand. Debbie.
Yeah, it was just about the prescribers. Because we had a number of pharmacists, some are prescribers and then one wasn't, and she was working for the PCN. So we book every 3 months, we book our clinical pharmacists and prescribers out with a GP, and they audit a set of notes. It's like 10 sets of notes that they've worked on. But we weren't doing that for the non-prescribing clinical pharmacist. Because, well, we just weren't, and we weren't sure if we should have been doing or not doing because they weren't prescribing. But also it's the amount of time out for GPs as well, because we're getting more and more R's. It's more and more time out for GPs, and before you know it, it's hardly worth having that extra person helping, because you're just losing it on GP time as well. So it's hard to strike the balance.
It's as like Divesh said, we can't tell you what to do and how to do it in supervision terms, but it's about your assessment of their competency. So it could be that there's somebody that you've worked with for a long time, you're used to them, you've assessed them as competent to work with, for example, diabetic patients or whatever, and that you're happy with that, and you then reduce what you do in your oversight because you're happy with their competence. So it's about people working, because although your clinical pharmacists, they're independent prescribers, but they will have areas of competence. They've not been trained as a GP. They are in different areas. So if you're comfortable with their competence in a particular area, you would reduce what you need to do in that area. If they're coming into a new area and you're supporting them to work in a different type of clinical setting, then you would have an increased supervision there.
Thank you.
Yeah, just to
that's sort of the way we look at that.
Really, don't forget this is an iterative process, as this is happening constantly over time. So I guess there is an expectation. A lot of the supervision and development of skills and things is front loaded and therefore takes more amount of time. But as it goes on over time, that probably expectation, both on the part of the lead clinician as well as that being trained would probably reduce somewhat.
And Helen's asked how often the Arden searches are updated. There isn't a specific timescale. We meet once a month as a working group around the searches with Ardens and with our clinicians to see what needs updating. So there may be tweaks and changes, but they're not fundamentally changed. They're not expected to be fundamentally changed in the short term at all, because we need to be able, part of the whole point of inspection is that consistency and how we're looking across. So there may be tweaks, and obviously they'd be changed if something new guidance came out about a drug that's on our searches and we had to change something, that would obviously be changed straight away. But other than that, it would be a much slower, more iterative process of where we think we're finding a lot of problems with this. Let's look at that further. We've also pulled in some of the risk levels because we had them quite wide, particularly because of COVID. We were looking, quite a lot of leeway, and so pulling in some of those a little bit closer to recognise guidance, rather than having more of that leeway that we would have expected during the pandemic period. So some of those get tweaked, but not majorly changed.
And is it fair to say as well, Mary, if tomorrow like a really important alert or something like that came out, that would probably be prioritised in the working group, probably be put forward a lot sooner than something that may not have as much sort of patient impact.
It is about impact, patient impact. So, if there was a sudden high risk, that would go in there.
Oh, I think Khalid, have you got your...
Sorry, can I just answer, just come back on that question? Is that...
Yeah, sure.
So that's really useful, thank you, because I kind of went into Ardens last week and noticed that we were on an old version, so I think it's now version 1.5, but I've just quickly had a quick look at so obviously it's like all the other Ardens searches, they're just getting updated periodically, and it was just good to know that maybe we might be informed if there was a major update.
Yeah, if there were really major things, if it was something outside of what you'd expect to see, if we'd had a big drug alert come out that really, shook everybody and we'd expect everybody to know, that would just be expected. But if we suddenly decided to actually, we're going to focus on XYZ, or we're going to start looking at this that's very different, there would be some comms coming out about that.
Yes,
and certainly as part of our engagement would be part
Thank you. And I'm just looking at, we do look at ours periodically, but the lithium one is not picking up the calcium, and I think there's a slight coding issue there, so I've just made Ardens alert. So I guess
if you notice any issues or any coding issues, please go to Ardens, and they look at that, and then they come to us and say if there's something that needs to be tweaked, because we have picked up a couple of little tweaks with the coding that maybe it doesn't always, something doesn't quite pick up. So yeah, that's really helpful. If there's anything, we have gone through user testing, and we've gone through can you break it, and said that
it's just labs in different areas have got slightly different codes, isn't it?
Yeah, so that's great. If there's any that you can alert us to, that's really helpful.
Okay, thank you.
Was it Dr. Butt, Khalid? Yeah, in a question.
I think the slight difficulty we have locally is that we employ many of our additional role staff through an external organisation called PICS. It's a GP sort of led organisation who are responsible for HR, and they do help a lot with the supervision of their training and competencies. For pharmacists, we have a lead pharmacist who supervise over, as an overarching supervisor for them, do the annual appraisals, also is the kind of lead for the education and training updates, arranges sort of peer reviews of them and meetings between pharmacists and all the rest of it. So some sort of assurance that they've got the relevant competencies from PICS in writing obviously is essential, but then maybe just do something internal in your own surgeries to make sure that they're working in the surgery within their competencies. So what I'm saying is it may not be too onerous, as Debbie seemed to suggest, if PICS are quite closely related, and we're getting assurances in writing from PICS of what's happening for their supervision, training, and the rest of it.
Okay, yeah, no, that's a fair point.
Yeah,
and I think you alluded to it anyway there. I mean, the key thing is that the practice itself has that assurance of that competence, whether it's done by this PICS provider or whether you feel like as a practice you have to maybe top up that training as well to get to that adequate level. That's the key thing, I guess, from obviously your perspective as a practice, but also what we're looking for in terms of our inspection methodology too.
That's the thing that somebody else has asked a similar sort of question. It's what we're inspecting is the regulated activity that is being undertaken at the location that is your practice. So we're inspecting that you have assurance of the competency of the people that are providing that regulated activity. So your assurance may be somebody else has done it and I'm confident with what's been done, or it may be that I've done this. So it will be, it won't be one size fits all, but we're not regulating in a way, we're not regulating the competency of the person, but that you have assurance of that competency of that person. If we were to question that competency, are you able to show that you've had that assurance? So yeah, and having that evidence of that for yourself. So if you're saying their competency has been assessed by this external or a different place, what's your evidence of that, so that you've got that as your assurance? I think it's Debbie want to come back on that.
It was just to Khaled, really. I think it was during one of our old CQC inspections. We were asked to provide evidence that we'd gone through and audited patients' notes that they'd worked on. So I guess we're probably a bit risk averse because obviously PICS won't have access to our patient system, so they can't actually go through patients when they're doing their appraisals or anything. So that's what was taking the time, really. I mean, I think the GPs constantly are looking, because obviously when they're consulting, they can see if anything is adrift, and they'd soon pick up a trend or a pattern. But it's what you can document, I think, sometimes, and what you can prove on an inspection.
Yeah, that's the case. It is about being able to evidence that you have that assurance somehow. And if you have done it in a different way, then being and we come in and say, have you audited notes? You say no, but we've done this. Is that can you show that, and will that be different? We won't necessarily, we shouldn't say you must do this, but can you evidence that what you've done is of a suitable quality and gives you that confidence? Yeah.
Hand up by Aaron, I think, is it?
Yes, I just wanted to follow on from what Debbie was saying. We have recently gone through an inspection where this question was asked. We had assurances on training from PICS for the staff that for the R staff of the practice. We were told that we were still expected to have individual sign-offs and audits from our GP in addition to. So that was just to put in from we've literally had one last month, so it's that's what our experience.
Okay.
That's interesting, and I think that is a point that we will take back as well, to make sure that we've got some consistent messaging coming out around inspection and that point. So we will take that point back as well. And if necessary, we can change, because we do have Mythbusters on this issue, and we'll make sure that they're up to date with what the inspection colleagues are saying.
Can I just come back on that point? I think we're all singing from the same hymn sheet, that there still needs to be some sort of assurance that they have of education, training, updates and all the rest of it. But then there needs to be some sort of insurance that within the practice, they're actually working within their competence. And that's a bit where I think Aaron and Debbie sort of saying that we need to make sure we've got that.
Emma, I think, did you have your hand up as well?
Yeah, it's just more of an ask, really. We've heard of some inspections recently where the clinical pharmacists have asked questions of non-clinical staff in terms of how is the creatinine clearance ratio calculated. They've asked that of a receptionist who obviously it's well out of their
Yeah.
scope, out of their competence, but left them really quite shaken up because they didn't know, had no idea what they were talking about. So when your sort of inspectors or pharmacists are going in, can they just be aware of who they're asking clinical questions to, please?
Absolutely. I mean, there is obviously, we've trained our staff, but there is an expectation that as clinicians, we only speak to, I guess, not only, but primarily speak if we have issues around things like creatinine clearance or clinical aspects to clinical members of, the practice team, whether it's a GP or another pharmacist or anyone else. But we'll definitely take that back.
It's a good point to raise, particularly with our specialist advisor team who are sort of contracted to work for us, and it's a good update that we can give to them. Thank you.
Thank you.
Do we have any other questions? I can't see any others on the chat, but I've got the hand up. No. I think if not, then I think we can probably leave it there, Stuart.
Excellent. Thank you very much. I do a last call for questions just in case, but are there any questions for Mary or Devesh at all?
Can be about anything to do with CQC. We're happy to take questions about anything. If we
Yeah.
can't answer them,
There we
we'll
go
find
then.
somebody who can.
Sorry.
We can't promise we have all the answers, but,
but
Yeah.
we probably know somebody who does.
Yeah, I think I don't know if I missed a bit of a training session like a while ago, but I always struggle with the statement of purpose, how to amend it, what I should be amending, why I'm amending it, because I seem to have to amend it every time I have a change in partnership. I think because I didn't have that initial training and I kind of inherited that part, it was yeah, it's not that clear, I don't think.
There is some, well, I can link it. I'm not an expert on statement of purpose, but there is the thing with the statement of purpose, particularly in GP practice, because you have a lot of changes around, partnerships and working. Normally, we'd expect a service to change their statement of purpose when they change what they're doing. So they introduce a new type of service that wasn't on their statement of purpose, or you'd start doing certainly in independent health, they suddenly start doing a slimming clinic or something, and you have to put it into your statement of purpose. So you're changing the activity that you're doing within that regulator. You're not changing to a different regulation. You're within your regulated activity of TDDI or diagnostics and screening, you're doing something different. But because of your changes in partnership, that's where you need to have those changes. There is some information on our website around statement of purpose, which I can find, and I'll try and link into this chat.
Somebody's done it, yeah.
But there is some information. You can, if you do get stuck, our NCC, our call centre are quite good at being able to support.
Yeah, they've helped me before, to be fair.
Yeah, if you do get stuck, they're pretty good at navigating.
Yeah. And just one more question, really. During any new inspections, after COVID and realising our workload and the introduction of PCNs, practice managers are swamped, all the rest of it, all the over and above nice stuff that we was expected to do is that to go on the back burner. Like this year, for example, I've parked doing research or, all the kind of accessing certain groups of people because we just haven't got the time. Are you taking all that into account now?
It is taken into account. It's part of your whole inspection will be explaining that. So if we turn, we have to do, there are certain things around safety and effectiveness. We're looking at responsive, so we might be looking at, access. We're looking very much at access. And then some of that stuff where you say, actually, we did work on this, but now we've got to do this, and this is something we can't do. It's whether that prioritization seems right. If you suddenly say, well, I'm not doing any childhood IMS because I haven't got time to do them, then we'd think that was the wrong thing to do.
Yeah,
and you've got to do. So it's where you're focusing and where that work is. So it's not that we'll ever say, don't do the nice to do's. It's perfectly okay. Don't do that. Don't do this. It's about how it works for your practice and your population, and whether you're, if you're focusing on the things that are really needed for your population and have parked some of the things that are less important.
Yeah,
the population
it's
group
just
that
quite
you're
hard
serving.
to achieve that outstanding now, really, if not impossible. But actually, you can be outstanding just by doing you know,
What-
everything
yeah.
that is contracted and needed, rather than focusing on more
Outstanding
of the
is
social care.
quite a contentious thing, and it is quite difficult.
Yeah.
And I think outstanding, when we first started inspecting GP practices, I remember Steve Field, our lead, was he said, if it's outstanding, I've got to be able to want to get in my car and drive there and see it, because this is something that somebody else isn't doing. And it's something that somebody else isn't doing for your population, because what is
Yeah.
outstanding in one population is not necessarily the same in another. So it's some of those areas that are, you know, we've had some things come through as outstanding during COVID because of how people have managed particular challenges within their practice group, and particular challenges that they have managed that have pushed into outstanding.
Yeah, it's just you can have a low good and a high good, and I
Yeah.
just think there needs to be something in between, because it can be
Ooh,
quite
well,
demoralising.
now you're talking,
really.
because guess
So-
what's coming next.
Yeah.
So looking to
Okay.
the future, there will be more of a scoring type
Scoring metric. Yeah.
process. If you can get one, if you are interested in having our a provider engagement team come out to speak to you about the future, and how that scoring would work, and how high goods, and you know, there would be more of that range around, and scoring certain things. So the changes in our regulatory model will allow some of that to happen in the future.
Thank you.
We don't know the details. I mean, provider engagement know a bit more the detail than we do probably at this point, but there will be that sort of scoring, and yeah, because we look at services and we go, well, that's a cuspy one, or that's a high good or a low good, and
Yeah.
you know, that's how you look at them. But we will be able to do a bit more scoring to give that variation.
Good. Great. Thank you.
Great, thank you, Mary. Thank you, Divish. So I've just put in the chat, I've asked my own question. Do you have national examples of outstanding, how this can be achieved?
You can, for outstanding, if you go onto our website and you search for reports, you can search for just outstanding and just GP. So you can filter to find the ones that have been published recently to see what's coming out. It's yeah, and all our ones that are anything that comes out outstanding does go through a panel, so that it is judged alongside others, so that we make sure we're being a bit more, you know, that outstanding comes out as consistent.
Yeah.
So you can filter your search to find outstanding and see what's outstanding.
Excellent, thank you very much. Helen Davies also just put in there, following the CQC, ethnic minorities-led GP practice impact and experience of CQC regulation, published January earlier this year. So is there increased awareness of health equalities by all the inspection team?
We hope so. We are working very much on health inequalities. It's one of our key planks of our new strategy. And it is, we have a team that leads on health inequalities. We're doing certainly, speaking as for the medicines team, there are certain particular areas of health inequalities that we're keen to focus on. For example, in our hospital work at the moment, we're looking particularly at sickle cell, treatment of sickle cell, and certain different things there. So it is one of our key strategies, and something that we really are working with. That will be part, and it is part of a discussion, as I know when I sit on a panel that discusses a report, that that is something that comes up and is discussed about individual reports. So I think my answer really is, I hope so, and we're working on it.
Okay, thank you. Right, excellent. Well, again, thank you very much for coming in today. Really do appreciate your time and presentation, because I think it's really useful for our practicing colleagues to know. So thank you. I can't thank you enough, really. I think it's been really useful. And also thank you for letting us record this session as well, for those who can't be here today. So lovely seeing you both. Stay safe, and hopefully we'll see you very soon. Maybe come back, if you don't mind.
In this forum rather than on an inspection, that's what you want.
Yeah.
Yes. Thank you, Mary. Thank you, Divish.
Thank you.
Thank you.
Thank
Thanks
you.
everyone.
Take care,
Bye.
guys.
Enjoy the rest of your day.
Thank you.